here also that there will be online record for the audience who join us on the online for this one. So I will start by the first presentation about clear or quick introduction about antimicrobial stewardship overview and what I need to measure like as outcomes. So let's start by the objective. So we will discuss about the history and from where we get the rationale for antimicrobial stewardship and type of ASP strategy in addition to metrics and outcomes. So when we mention antimicrobial, we including 4 medication because you will hear antibiotic stewardship program or antimicrobial stewardship program. So antimicrobial is a broad including 4 type of medication, which is the antibiotic that deal with bacterial infection, antiviral against virus, in addition to antifungal against fungal infection, and also antiparasitic, which is the medication that used to treat parasite infection. As you know, antimicrobial resistance is a concern nowadays, and WHO now identified the AMR as one of the biggest threat to the global health. This is a scary publication that estimates that by 2050, there will be a 10 million deaths, exceeding even the cancer due to antimicrobial resistant organism. So antibiotic is a unique. Most of the medication, the effect will be related to the same patient, and that's it. Late diabetic medication. But when we came to the antibiotic, use of antibiotic has impact not just for the patient, but also to the global community. This is very important concern. If you take home message from my presentation, this you will get from where we have the spread of the antimicrobial resistance. So we have the antibiotic here. George gets the antibiotic and develop resistant bacteria in his gut. George can join the community and spread the antimicrobial resistance to the community. Or maybe he admitted to the hospital and due to poor infection control, it will lead to spread AMR to the other patient, to the healthcare worker, and again will be discharged and it will be spread to the whole community. On the other hand, antibiotic also used in animal. This is very important. So when animal use antibiotic, it develop a resistant organism again in their gut. It will be, if not cooked well or not used well or not, it will be eaten and then again, it will be spread the resistance to the community and or could lead to fertilizer or water contamination animal feces that lead to contamination of the crops اللي هي المحاصيل. حتى المحاصيل always could be contaminated with AMR that could lead to drug resistant bacteria and again it will be spread to the community. Imagine more than 13 million kilograms of antibiotic has been used in animals in US. See this huge number, 13.5 kilogram of antibiotic is used in animal. This part, also there is like 70,000 kilogram in crops, محاصيل, bits, 150,000 kilogram of antibiotic used in bits, and also in agriculture اللي هي الحاجات المائية. So 3.2 million is used in human. There is another study in UK just to see what's the distribution of this antibiotic among human that use in human. So, and they found this green color, when you make the human there, and you want to see from where the distribution of the antibiotic, the green color indicate that this antibiotic used in the community, while the red color in the hospital, and the gray one, I think in the dentist, and then they were in the other community. So a majority of antibiotic used also in the community. Only the red part has been used in the hospital. This is very important to know the situation of the antibiotic consumption. you will hear about this term, and this is very important term, which is the One Health approach. You will hear this term by WHO, by CDC. So what's the definition of One Health? One Health, that's mean that you need to have a healthy animal, a healthy environment, and a healthy human. Not only focus on the human and leave the other two. Imagine antibiotic like colistin has been used in camels here in Saudi or in animals. This is very crucial. So we need to control the antibiotic use in animal and also in the environment. Why you are concerning about environment? Any idea? Industrial use, for example, the antibiotic, المصانع حقت الانتيبيوتيك also could lead to contamination of the soils. What else? Nowadays, I attend one of the symposium about invasive fungal infection, and they found also there is a fungal resistant, and one of the risk factor for that it's using of fungicidal in the, for example, in the planet, in the plants, in the animals, in the, so using also these antifungal could also lead to unhealthy environment. So nowadays there is an approach called One Health approach. So you need to tackle all of these. And nowadays we have a good collaboration in Saudi between وزارة الصحة, وزارة الزراعة to control these antibiotic. And it will be a good achievement, inshallah. This is the same concept. So as a consequence, WHO, due to AMR, create a national action plan back in 2015 to raise the awareness of the antimicrobial resistant. Also, in the same year, Canada also created a federal action plan to combat antimicrobial resistant. They make a meeting inside the United Nations, داخل الأمم المتحدة, to discuss about antimicrobial resistant back in 2016. Also, European created a One Health action plan in 2017 to combat antimicrobial resistant. And in the G20, where is the most of the agenda is economic, they discuss about AMR and the burden of the AMR on the healthcare system. How about our kingdom? Here in Saudi, also we create a national action plan back in January 2017. And now there is an update by this national action plan. I urge everyone to read this. Very important to know what's the concept of our national action plan in Saudi. So one of these, they mentioned that the objective of the plan will be achieved by implementing the following strategic activities to combat the antimicrobial resistant, and one of them or two of them implementing infection control program and implementing antibiotic stewardship program in each hospital in Saudi. Accreditation requirement in 7, 8, 9 May, there was a Sabahi visit to our hospital, National Guard Jeddah, and they go through over standards. So there is to check about the antimicrobial stewardship. Also, Ministry of Health, they came 21 and 22 of May. They go through all over infection control issue and also about ASP. So all of these accreditation, they know they want to see if there is ASP program in the hospital or no. And this JCI also is an accreditation requirement for the ASP program. This is the standard of Sabahi. So they go through all of these elements to accredit your hospital that it's met or not met. So the hospital implement updated and approved multidisciplinary guideline on the proper prescribing of antibiotic. They want to see clear evidence that you are implementing guideline in your hospital. The antibiotic guidelines are updated as recommended by the Pharmacy and Therapeutic Committee, which is a P&T committee. So they want to see what's your guideline that updated and recommended by the P&T committee, and they discuss that in the agenda of the P&T committee. There is also proper implementation of the approved guideline for antibiotic prophylaxis. In the Sabahi visit, they mentioned that open one of the patient file and show me this patient going to surgery and what was the antibiotic was given, and they want to check what are the prophylaxis was given. So this is to want to make sure that there is a clear guideline about prophylaxis antibiotic before surgery or dental procedure. There is also proper implementation of the approved guideline for empiric or therapeutic guideline. You have a guideline for brucella, guideline for febrile neutropenia, clear in your hospital. And also there is a proper implementation of the approved prescribing privilege for the antibiotic. By the way, nowadays, Sabahi, they will make, as there is a infection control standard, they will make ASP standard soon. And it will be, again, one of the accreditation for your hospital. So this is the part that related to the ASP in Sabahi. How about JCI? JCI, this is an old one, old standard. So they mention clearly that the hospital develop and implement a program of antibiotic stewardship that involve infection prevention and control professional, physician, nurse, pharmacist, trainee, patient, families, and other. They want to make sure that there is a ASP team in your hospital to meet this standard. The program is based on scientific evidence, accepted practice guideline, and also local laws and regulation. And also here, the program include the guideline for optimal use of antibiotic therapy, same one as Sabahi, and there is a mechanism to oversee the program of antibiotic stewardship. Okay, you have the ASP, but show me what are the outcomes for this program. Is there any outcomes you are measuring? And the effectiveness of the antibiotic stewardship is monitored. So this is JCI. By the way, there is an update JCI, Sabahi standard in January 2023. One of the element that, or two element was added. One of them, they want to make sure that there is also ASP in the outpatient clinic. In addition to, they want to make sure that each healthcare worker has a competency test for ASP. So show me what are you doing, for example, as right care right now or infection control, what are you doing for ASP as a competence? And they make it as a one of the standard for JCI. This is crucial. Why I mentioned this, by the way? Any idea why I mentioned this guideline as standard and accreditation? Huh? This is number one. Number two, لما المدير عندي في المستشفى ما يعرف ايش معنى اس بي، انت ايش بتسوي انت هذا؟ This is a standard. This is a citation. When there is a citation from JCI or Sabahi, no, there is something wrong. So they will give you full support. So this is a good opportunity to discuss with the administration about the standard, especially when it's not met, because we are lacking of the antibiotic stewardship program. This is the MOH تعبونا بس في infection control, not for ASP. So again, there is a written policy and procedure for antimicrobial. This is دي يعني معناها document. They want to see a document that there is a ASP committee, authorized ASP committee, and also shared by clinical pharmacist or infectious disease consultant with a clear role and responsibility and meet on regular basis. We have a regional and corporate antimicrobial stewardship in National Guard Hospital that meet regularly on these spaces. Also, there is a written restricted antibiotic policy implemented in the facility. There is also interventional policy implemented to improve antibiotic usage. I'm sure that you are MOH, they visit all hospital. Are you aware about this standard? Yeah, because they came like every quarter or 2 times to all hospital in the kingdom to make sure that these standards are met. Antibiogram is regularly discussed by antimicrobial stewardship. They want to see there is items in the ASP committee discussing antibiogram. In addition to, hospital leader dedicate the necessary human, financial. So here you will seize the opportunity. I need to have a clinical pharmacist and also ASP team, and I need your support to go up with this program. And the antibiogram report also is prepared and discuss education about AMR, antimicrobial resistance. So all of these are the standard for the MOH visit. So there is no question that antibiotic use is the most important modifiable factor in tackling the problem of antibiotic resistant. Benefit of ASP, huge benefit of ASP, decrease the cost, decrease the unnecessary use of antimicrobial, decrease also the C. diff risk, the allergic, the side effect of the antibiotic, and increase patient safety. I'm sure all of you know this one. Right antimicrobial, right patient, right time, at the right dose, with the right route, right duration, right documentation, equal least harm to the current and future patient. This is the concept of antimicrobial stewardship program. It's a critical balance between two things. I want to make sure that the patient in the beginning, they receive the right antibiotic. صح؟ لأنه if I'm not give him the right antibiotic in the beginning, mortality will be increase. مو معقول انا عندي عندي الريزيستنت في الهوسبيتال واروح اعطي مثلا سيفترياكسون. صح؟ So this is could lead importance of appropriate empiric therapy, because if we're not giving appropriate antibiotic therapy, it will lead to increased mortality. On the other hand, if I give broad spectrum antibiotic, will lead to AMR, antimicrobial resistant, side effect, and risk of toxicity, adverse drug reaction. Here, where is the balance of the ASP? You want to make sure that identify the source of the infection to narrow empirical treatment and to do de-escalation therapy to the empiric with a culture and sensitivity. Strategies. What are the strategies for ASP? There are what's called أنا قبل before I am starting the antibiotic or after starting antibiotic. So before starting of antibiotic, what are the strategies? أمنع كل حاجة صح؟ Formulary restriction صح؟ What else? أنا يهمني before I'm starting any antibiotic. List of, I want to make sure there is a list of antibiotics. No anyone can write, for example, مربنا ولا سفتاز آفي ولا any antibiotic. هذا before I'm prescribing antibiotic. What else? Also a strategy for ASP before I'm prescribing antibiotic. Guideline صح؟ There is a clear guideline for UTI in hospital, in our hospital. Clear guideline, for example, for febrile neutropenia. أنا عندي في febrile neutropenia in our hospital, you need to start patient on tazocin, piperacillin, tazobactam, and amikacin. When I came for a patient with febrile neutropenia and I found him on meropenem, so you are not following guideline. صح? So guideline before, it's a pre-prescription strategies. Education, very important. Antibiogram. Before I'm starting antibiotic, I will look for our antibiogram. صح? This is a strategy before starting antibiotic. Selective reporting of susceptibility testing. LUTI came to you and now all sensitive. Why I need to use broad spectrum? It's sensitive, for example, to cefazolin or cephalexin. Confirming patient allergy صح مو مهم. Before, this is a strategy also before. If any patient they labeled as allergic to penicillin, so I will try to use more broad spectrum antibiotic. And at the end, it was allergy. It was like not true allergy. So this is one of the strategy before and prescription. What about post? Audit and feedback. أبدأ أنت لكن أنا I will come to you to discuss. So post already prescribed the antibiotic. So it will be audit and feedback, monitor appropriateness, monitor utilization, and also education, electronic solution. Like for example, إيش? The antibiotic will be running in the system for 3 days, but then it will be stopped. This is post-prescription strategy. IV to oral, switch, for example. خلاص the patient after 3 days, he's tolerating orally. Why you need to keep him on IV medication? So this is a strategy post-prescription of the antibiotic. You need to measure something. ASP, if you have ASP program, you need to have outcomes. What's your outcomes? Two types of outcomes. Either what's called process outcomes or outcome اللي هو الاوتكم ماتريكس. البروسيس ماتريكس ايش هي؟ يا سلام، دي او تي، حاجات البروسيس اللي هي health care service provided on or behalf of the patient, like guideline. انا حطيت guideline. This is a process. تمام. دي او تي length of stay or sorry length of therapy and cost. As an outcome I want to make sure as outcome أنا لما طبقت الجايد لاين I'm not increasing the mortality. صح؟ أنا صح قللت الدي دي دي but I increase the mortality. So I want to make sure that this is what's called outcomes metrics. CDIF, and when I apply these measures as a process, I reduce the CDIF. تمام يا شباب. This is what's called outcomes metrics. Antimicrobial resistant. الانتيبيوجرام حقي improved. So this is outcome process. It will be explained inshallah by Dr. Bashair. I will skip. This is our outcomes in National Guard. So we want to make sure that all these is met in our hospital, which is multi-drug resistant organism prevalence. This is what? Process or outcome. هيبدأ عزيز ايش رايك؟ لما تقول انا الاوتكمز حقي multi-drug resistant organism prevalence rate MDRO. This is outcome, صح؟ This is outcome. Carbapenem resistant organism CRE outcome. But antimicrobial defined daily dose, this is a process. Metrics, cost or days of therapy, antimicrobial cost, sometimes also it will be outcome. And by decreasing meropenem, for example, ستاز افي قللت الكوست للهوسبيتال. CDF outcomes. طيب. Key message from my presentation: misuse, overuse, and inappropriate use of antimicrobial contribute to the antimicrobial resistant, and stewardship program should be implemented in all healthcare nowadays. No excuse. As per JCI, Sabahi, MOH, and antimicrobial stewardship program can result in increased patient safety, improved resistance, and also significant cost saving. Right. This is a very important resource. You can get a picture for this. Very excellent resource that still I'm using it also when I trained in Canada, that this is the one of the resources, especially the WHO course. Usually in our hospital, we do like a competency or a winner test for those who apply or bring a certificate for WHO course of the for the. This is another useful resource for antimicrobial stewardship, and they will tell you which strategy is difficult or can be applicable or can be easy also to applicable in your hospital. طيب. I'm done with the first presentation. Any questions? We will make it as interaction. I'm happy to receive any questions about the JCI. Is there, so how many hospital here? Which hospital? نجران. صباح يجوكم كل ما يحتاج يعني. هوسبيتال فين؟ الرياض ولا جدة؟ الطائف ما شاء الله. رياض. معانا انت. كينج فيصل هنا في ها؟ الرياض. شرق جدة. طيب. Any questions؟ جلستوا مع سباهي؟ يمشوا على كل واحدة واحدة. You want to make sure that they are already.
Thank you for your good presentation, Doctor. My question regarding the animal and environment stewardship program. Any applicable steps in that area? Anything done already? I think we are agreeing in that area. Thank you.
You mean the environmental? Yes. As I told you, there was a collaboration عندنا يعني هذا بصراحة ما تنقال. There was a collaboration between وزارة الصحة and وزارة الزراعة. A lot of meetings about the restricted of antibiotic use in animal. They want to make sure that, imagine that also antibiotic has been used also for fish for without restriction. So that's why many collaboration between these two ministry to make sure that there will be a good control of the antibiotic use. Dr. Bashar, you want to start your presentation? We'll start with the second for Dr. Bashar.
Thank you, Dr. Maher. It's hard to follow after your through presentation. I would like to start with, there are some concepts that Dr. Maher talked about. However, we might elaborate more, and I want it to be as interactive as possible. And feel free to, if you have any question, to interrupt me at any point. So this is something I think Dr. Maher touched on. Antimicrobials or having an effective antibiotics have changed the face of medicine. So having effective antimicrobial have made transplantation, chemotherapy, neonatal care possible. Without having those effective antimicrobial, all of these procedures wouldn't be possible in these days. So Dr. Maher said, we are facing resistant, and this is something that it's not something new. It has been going on since 1920s when we discovered penicillins for the first time. So we have resistant. So why don't we, when we have a resistant from an antibiotic, we discover a new antibiotic, so, and so forth. I'm sure, like, if you're reading updates from diabetes or reading updates in oncology, you'll see a lot of medications that are approved all of the time. So, like, for example, diabetes, they do update their guideline yearly, similarly with oncology medication, simply because antibiotics is not a profitable business. It's not something that drug company would like to invest in that much. The reason is the duration of therapy for infections, let's say 7 days, 10 days, and stewardship comes and say, I want a less duration, I want switching, I want narrowing. So it's not something that is profitable as other chronic illnesses. So that's why you're gonna see that the discovery of medication is not that much if we're gonna compare it to others. And this is why we need to reserve the antibiotics we have. And furthermore, even with new antimicrobials that you've seen, novel antimicrobials that are introduced in the market recently, we are still facing the risk of resistance if we are continuing to misuse or abuse their prescribing. I'm sorry, what did I do? Okay, so I think this is something that we've talked about. The misuse could be from us in the hospitals, it could be from the community, and it could be also from food product, animal product. Antimicrobial stewardship program is something that started in 2007 through guidelines that was published by the IDSA, and then it was updated in 2016. So it's a collaborative effort that to make sure that there are some principles that we need to follow. The principles of ASP is having the right dose, right route, right duration, right indication, and the most targeted antimicrobial. And as a result of this principle, we need to create a team that can work collaboratively within the healthcare system to ensure that these principles are being followed in every step. So we can select appropriately. However, if we are dosing it inappropriately, this will lead to resistance. Why is dosing so important with antimicrobials? Can anyone tell me? So if we underdose, what's the risk? If we overdose, what's the risk? Exactly, side effects, which is with all other type of medications. And underdose, exactly. So if, let's say, a patient is on an antihypertensive medication and we did not optimize his medication and his blood pressure was not controlled, the day after we come and we adjust the doses. Yes, there is a little bit of harm, but it's not as when we are not appropriately dosing an antimicrobial. We're giving the bacteria the chance to develop resistance from this small dose. So this is why dosing is very much important, and this is something that is as important as the choice as well. Optimization of duration, this is also similar to doses. So if we are giving a duration that is beyond what is recommended, then we are increasing the chance of selective pressure and resistant. And if we are giving a duration that is less than what we need to give, then we will come with treatment failure, relapse, reinfection. And again, we're using different type of antibiotics and adding selective pressure on antimicrobials. So this is why it's important: selection, dosing, duration, and you're always going to see this specifically when you're reading the guidelines, the local guidelines in your hospitals. They do focus not only on selection, it should be focused on duration and doses as well. So I think Dr. Maher talked about this. We want to optimize clinical outcomes through these ASP program. We want to reduce adverse event. We want to reduce antibiotic resistant, and we want to reduce healthcare cost. How do you think antimicrobial stewardship can reduce healthcare costs? Yes? Yes, exactly. So if we are, for example, reducing the risk of resistant, then we are reducing hospital stay as well. If we are reducing the risk of recurrent or relapse, we're reducing hospital readmission. If we're switching from IV to PO as well, we can reduce the cost. If we are narrowing spectrum, we can reduce the cost. If we can switch to oral and discharge the patient instead of him being in the hospital, we are reducing the cost as well. So there are different aspects of reducing the cost. So you would see it as something that is not as important as resistant or C. diff infection or clinical cure, but you would always see it there. The reason we always put it there, as Dr. Maher said, we want support, right? Support from administration. We want support in terms of staff that are dedicated for stewardship. We want to hire people that can help in stewardship. We want softwares that helps us calculate the outcomes. So if we can prove that we are reducing healthcare costs, then this might also make it more attractive to administration to support these types of program. And this is why it's important to include it in the outcomes. So we do have limited antibiotics. Misuse is common, as Dr. Maher said, and it can negatively impact patients. And this is why we do need an active antimicrobial stewardship. So the ASP team, who do you think should be included in the ASP team? Of course, we always love to say that everyone is a steward in his area. And everyone, it's not only ID or ID physicians or ASP or ID pharmacists are the one who are responsible for ensuring these principles. Everyone should have an impact on that. But if we are creating an ASP program, it has to have, as we said, there should be a collaboration. So it should be a team that is consistent of different members. So according to IDSA, they have to have an ID physician and co-led with an ID pharmacist as well. The ID physician insight on this is proper indication, de-escalation, taking the decision in terms of this patient doesn't need antibiotic at all, for example. This patient has something that is viral. So the physician is very much important member of ASP team. It cannot be a successful program without having an ID physician. A pharmacist could take care of the appropriate dosing, the appropriate duration, the pharmacokinetics, the IV to PO switch, in helping formulating the guideline as well. Of course, if we want to have a dream team, then there are some other members that could be also involved, such as clinical microbiologists. We will have a very important impact in terms of looking into cultures, educating, also doing guidelines in terms of labeling or dislabeling microbes. Also, infection control professionals, hospital epidemiologists, IT specialists to help us in measuring the metrics is also something we aim to have, but I think not every program, unfortunately, does have this team. I think we cannot have an effective antimicrobial stewardship without institutional support. And always, I think when you're starting, we don't get that much support until we show the outcomes that we are doing. So we always start small and then show the outcomes and then support comes. We do not expect that support will come from the beginning without showing the effect of antimicrobial stewardship. So I think these examples of intervention Dr. Maher talked about. However, I just want to make sure that these concepts are there. So we want to shorten antimicrobial duration. We want to de-escalate as much as possible whenever feasible. And we want to restrict the prescribing of antimicrobial. However, do you think if the only intervention we're doing is antimicrobial restriction, are we applying stewardship principles? Yes, no. Okay, so what's the problem with restriction? Or there's no problems at all? Yes, exactly. Yes, so the thing is, there are some patients who are, as the doctor mentioned, that they are critical. They do need antimicrobial, broad spectrum antibiotics, such as patients with sepsis, septic shock, febrile neutropenia patients. So there are a patient population that does need to use these restricted antimicrobial. Before applying restriction, you need to know your hospital. How exactly are you functioning? Is the ID team is available 24/7? Are they there during the weekends? What to do when a physician cannot reach ID? So these things need to be into consideration because we do not want also to compromise patient outcome as well. The other thing is when we restrict, it's just us being in the eyes of other specialties, we're just being difficult. We just want to restrict. However, this is something that is the first step of stewardship. We need to do more. We need to get engaged and teach people. And this is why Dr. Mah mentioned having guidelines. So help me use the guidelines, because no one wakes up in the morning and thinks, okay, I'm gonna misuse antibiotics and I want to kill human race. And this is not the situation. Sometimes I'm misusing because either I don't have the full information, either I don't have something that helps me to choose the appropriate antimicrobial. I'm not sure about the duration. I'm not updated in the latest guideline. So give me tools that helps me apply these principles you're asking for, and always educate me and update me in terms of what's going on, because everyone is so busy in doing their daily job that sometimes they miss these situations. And I think Dr. Maher will talk about prospective audit and feedback and how is this going to impact and change how other specialties look at antimicrobial stewardship. So have you heard of antibiotic timeout and stop orders? Anyone? Timeouts? No? Yes, exactly. So timeouts, it means this is a problem with prescribing antibiotics. So usually when we prescribe, we ordered, let's say, labs, cultures, imaging, and we prescribed empirically. And then we forget about them, we forget about cultures, we forget about labs, and the antibiotics continued. So this is an issue. However, when we have an antibiotic timeout, it means after 48 to 72 hours, automatically the order is either alerted or like comes with an alert or a stop. So I go and review back what I've ordered. If I've ordered cultures, then I go and review them. If I've ordered imaging, if there are certain labs that I've ordered as well. This can help the physicians to audit themselves, to audit their choices, and to see if sometimes they would say, okay, this is not an infection, then I will discontinue antibiotic, or this is a viral infection, I'm going to discontinue. Or, for example, the culture came back sensitive to a narrower agent, then I'm going to change. Or even look into the plan of duration as well. So this is something that is making the person audit himself. Pre-authorization, prospective audit and feedback intervention. I think Dr. Maher will talk about this when he resume his talk. Facility-specific guidelines and algorithm. This is very important. And you've seen that this is part of CBAHI standard, JCI standard, MOH standards, because as I've mentioned, help me choose the most appropriate antimicrobial. You want me to know the updated guideline. You want me to know the antibiogram, right? You want me to know also what can I prescribe, because not everything I can prescribe as well. So when you do these guidelines, you're helping the prescriber to make an easier answer to what he's asking for. So if he is facing a patient, let's say with a urinary tract infection, so what exactly should I order? What exactly should I prescribe? And then what I'm allowed to prescribe as well in terms of restriction and what was something that is allowed by his specialty. So this will help a lot in reducing error, reducing also confusion regarding the use of antimicrobial. Implementing pharmacokinetic monitoring services, this is also very much important because, again, if the doses of vancomycin are all over the place, so I'm expecting either treatment failure and resistant, or also side effects as well. Also specifically when you're using also aminoglycosides, because we know that it can cause nephrotoxicity that might be sometimes irreversible. So having a pharmacokinetic monitoring service, and this is usually you would see it led by pharmacy department, will really help in reducing these unnecessary, for example, level that is ordered, sub-therapeutics or supra-therapeutic level. Implement IV to oral antibiotic regimen, and this is very much important. So we can, we know that IV usually is a broader spectrum. So when we are thinking of switching, then we are thinking of de-escalating sometimes. And also there are some antimicrobials that have excellent oral bioavailability that we can switch to oral easily as well. And this will facilitate the discharge of the patient. So we're reducing hospital length of stay. So there are some outcome measurements that we would want to talk about. Maybe Dr. Maher talked about some of them, such as days of therapy, DDDs, and the process outcomes that he talked about. I just want to know from you guys what exactly the outcome measures you do in your institution, if you know about it. So do you do DDDs, DOTs? Excellent. Excellent. So these outcomes are common among hospitals. This is exactly what we usually do. We'll see what's the difference between each one of them and how to measure them as well. So there are some strategies that is very important, documenting indication. So I think this is one of the things that when we started doing in our hospital, we got a lot of hate. So there was, at one point, they can prescribe antibiotic without writing indications. And this is something that is the beginning of stewardship. If I don't know the indication, then how can I verify the dose? How can I verify the duration? How can I look at de-escalation? How do I know is this an effective agent? How would I follow the algorithm? So one of the things that we've insisted on doing as a process improvement is no order of antibiotic without an indication should be prescribed. So this is something, maybe a small thing, but however, it really changed the way we are processing the orders. So always, there has to be a documented indication when you are prescribing an antibiotic. We talked about stop, order, and time out, IV to PO switch, dose optimization, de-escalation. Of course, this is once we do have cultures, we look at de-escalation. Ensure appropriate dosing for patient on renal failure. And there is different recommendations for algorithm that should be done. So in your hospital, you should have a clinical pathway, let's say, or a guidelines for UTI, for C. diff infection, for cellulitis, for febrile neutropenia. The most common infections we do see, community and hospital-acquired pneumonia. And specifically when we're talking about hospital-acquired pneumonia, because you want to give them an insight on your antibiogram. So you want to show them, why are we choosing this over this? Because we have high resistance, for example, from one of the anti-pseudomonal agents. So it's very much important. One of the things also very important, and a lot of stewardship programs are now trying to implement, is penicillin allergy delabeling protocol. Have you ever heard of this? Delabeling protocols? Okay, so the problem is many of the patients, they would say, I have penicillin allergy. And it's written in his chart and forgotten. And it can be not a true allergy, right? So it can be something that was a mild rash or something that was not severe or not type 1 hypersensitivity reaction. And this will deny the patient from a very huge group of antimicrobial, which is beta lactams. So it will lead to unnecessary escalation of antibiotics. So sometimes some of the stewardship program takes this initiative to look at every patient who is admitted with penicillin allergy. So it's flagged that he has penicillin allergy, and they go and of course, usually they have an immunologist with them in that team, and they interview the patient, they take full history, and in case it wasn't a true allergy, then they will delabel the patient, and this will actually improve the outcomes in terms of admissions, repeated antibiotic use as well. We've talked about reports that can be done. I think if you're let's say if you're having a local local guidelines, then you want to see how much is your institution complying with that guideline. If you have, you should have actually 2 sets of blood culture in septic patient that is ordered. You want to see how well people are complying to this as well. So you want to, whenever you're developing an intervention, you want to measure this type of intervention, whether it's applied or adapted as well. Okay, so I think this is something that Dr. Maher touched based on, but I'll go over it very quick. So the clinical outcomes that we might look at, readmission related to infectious disease, and usually 30-day readmission rate. There are other things such as C. diff infection risk, drug-resistant rate as well, adverse drug events, days of therapy, antimicrobial errors, as well, de-escalation performed, which is in terms of numbers as well. So when we're measuring antibiotic use, as you can see, the easiest thing actually to measure is financial metrics. Why do you think it's easiest? Getting the data is easy. So getting the amount that you've prescribed yearly, the amount that you've purchased yearly, for example, this is an easy data to get. The further we go, it's kind of difficult to obtain these type of information. So defined daily dose is easier than if we want to measure DOTs. So how many of you do measure DOTs in their hospitals? Oh, mashallah. Okay, that's great. So it's not every hospital they do it. However, it's always if we want to look at the best evidence in terms of antimicrobial, because it is related to patient level rather than institutional level. So financial measures is, our financial metrics, let's say, is something that is easy to measure. We can measure antibiotic costs per year, antibiotic total spend as well, wastage, cost per discharge, cost due to readmission, cost through shortening length of stay. So we can measure this. However, it's more difficult when we come to the more clinical approach. So defined daily dose, I think this is something that most of us do measure. So we can check our performance month after month in each antimicrobial. And we can also look at other hospitals and compare our hospitals to others. But as I said, it's not a patient level measurement, so it's not going to be as accurate as the DOT. Something that is very much can be useful for all of us is an Excel sheet done by public health authority that can calculate the DDDs for you. So you can only open it and then enter how much number of vials you've used per month, and it will calculate for you the DDDs that is used for this antimicrobial in that month, and you can compare it to the use every single month. So this is something accessible for everyone. If you find it in Wiqaya, if you don't, you can come to me. I'll share with you the Excel sheet by the end of this. So DDDs, it's not perfect. However, it can give you an estimation of how exactly you're doing, and if you need to improve your utilization of a certain antimicrobial, and if there is an increase in your consumption from month to month, and at least every one of us should do these DDDs. Days of therapy is something that is related to the patient himself. So let's say a patient is taking vancomycin for or peptazole for 2 days and taking vancomycin for 6 days. So how do you think this is, if we want to say how many days of therapy this patient is taking from those antimicrobial? 2 days of peptazole, 6 days of vancomycin. What is the DOT? Yes, you should add it, but if you have 2 antimicrobial, it's also added to the DOT. So peptazole is 1, 2, and then vancomycin 3, 4, 5, 6. So it's a total of 6 days of therapy. This is difficult because are we going to do this on every patient, or are we going to calculate it from EMR? Usually there are some databases that can calculate this days of therapy. However, we calculate days of therapy and then we need to transfer it to 1,000 patient day. So we're gonna add all of the DOTs that we had that month and divide it by the total days of patient and then multiply it by 1,000. Of course, this is something that we usually don't do as stewardship because it's time consuming. However, there are softwares. This is why I was talking about IT specialists being with you to help you in calculating these DOT. Of course, there are prescriber metrics. This is something that I think physician will hate us for it. However, it's good to know that each service, how much they're prescribing antimicrobial, how much did they accept, for example, antimicrobial stewardship recommendations, what is the percentage of consult rates for these services. So this is something that is good, but you need to be careful not to offend anyone or not to use a prescriber name or not to be pointing fingers. The point is just to look at our practice and how to improve our practice. Dr. Maher, do you want to continue?
Let me ask you before we continue. So you mentioned about the DOT. As you know, about the counting of the days. If, for example, we say patient on meropenem, but we want to de-escalate to cefepime and metronidazole, are we increasing the DOT here, or what's the concept for that? ايش رايك بشاعر؟
So that's one of the drawbacks for DOT, that sometimes we are de-escalating, however, we are increasing. So that's why it's not the only metrics that we look at. And this is why it's very important to also measure how many antimicrobial did we de-escalate, the de-escalation, the acceptance rate of this, the other factors that we've talked about, the MDRO's rate as well. But yes, it might increase DOT, unfortunately.
Any question for Dr. Bashair? طيب. I'm gonna start with the third presentation, practical nowadays. So is it, can we go with a prospective audit and feedback, or what can we go with antimicrobial restriction? So I want from you to tell me what you have in your hospital. نبدأ بمصعب. Restriction in your hospital. شباب معايا في الفellowship. Do you have BAF? Oh, you have formulary restriction, pre-authorization. Which hospital? Okay. هنا ملك فيصل. Prospective. Do you have BAF? Both, mashallah. طيب, good, excellent. Also, we have both. So let's start. Can we go with prospective audited feedback or antimicrobial restriction? Which one is the best? Which one I need to apply in my hospital? So to know this strategy, how it work, and also to know the pros and cons for each intervention. طيب دبو قال حاجة قال pre-authorization صح? So we have many terms for formulary restriction. So we have what's called antimicrobial restriction, pre-authorization, or pre-prescription approval. This is all called formulary restriction. So pre-prescription for the antibiotic. Or we have prospective audit and feedback. This is my BAF round. We're doing BAF round or post-prescription review and feedback. So let's start by this diagram to understand what are or how these strategies are work. So this is the antibiotic started here. As I mentioned before starting of antibiotic called front-end strategies. So this is where is a pre-authorization or formulary restriction. It's here. صح? Before, Meropenem is restricted. No anyone can write Meropenem. No anyone can write Ceftaz Afi. صح? This is what's called pre-authorization. On the other hand, back-end strategy, already you prescribe the antibiotic, prospective audit and feedback. Prospective audit and feedback has maybe 3 categories. Fee at 24-hour to 48-hour. Here, if I'm doing a BAF round after prescription, after 24-hour, what are I'm targeting in BAF round? بس تبو بدل antibiotic within 24-hour. So what I'm targeting here in BAF round? 3 things. Any idea? Indication. تأكد إنه بدأ Meropenem because he has ASPL or something like that. Or dose, يا سلام. في 72 hour وفي day 7. So you can do BAF round at 24-hour to 48-hour or at 72 hours or at 70 days. So here I will do indication, dose, and culture. I want to make sure that culture was done. And at 72 hour, where is the majority of targeted for BAF round? You can targeting microbiology results. Now 3 days, all the micro lab will come to you. So you can assess based on that, patient respond. صح? Started on empirical treatment, day 3, he's doing fine, improving. This is targeting for BAF round. Also, confirmation of the diagnosis, de-escalation here also. And in addition to IV to oral switch, and also I can decide about duration also in these 72 hour. Type at day 7, what I'm targeting? So only duration. صح? At day 7. What you are targeting? Only you're targeting duration at that time for the BAF round. طيب. So 72 hours. So let's start by BAF round. ID pharmacist, physician works together. Usually they select drug or unit. I'm doing BAF round in ICU. I'm doing BAF round in oncology. I'm doing BAF round. So based on what? I will come in the next slide. So they review cases in the, for example, in the AMR, which is the electronic medical record. And they want to make sure that the patient has an appropriate antibiotic. They will also bug drug mismatch or streamlining or de-escalation. They will check the dose, they will check the route. So this is in the BAF round. So what are the strategy for BAF round? You know, أنا لما بسوي BAF round في ICU ولا في base, I will doing prospective audit and feedback based on which strategy? Any idea? ممكن تكون culture driven strategy. لما يجيني الميكروبيولوجي lab, I will see the culture, I will go doing BAF round. صح? This is called culture driven strategy. What other strategy? Drug. كل يعطيني ليست يا فارماسي كل البيشنت اون ميروبنا، صح؟ So this is what's called drug driven strategy. What other strategy؟ بعضهم unit driven strategy. انا بروح اسوي في الاي سي يو. Where is the most use of the antibiotic ولا oncology. So unit driven strategy. What's the last strategy؟ ولا antibiotic قلناها driven strategy. And I'm targeting all patient on Ceftaz AV that written. I'm doing BAF round for them. ولا I'm doing BAF round for meropenem. So culture driven strategy جاتني rapid diagnostic test result from the lab, and I'm gonna do culture driven or BAF round for those with a positive culture. In addition to unit driven strategy, I see oncology or diagnosis disease. صح؟ أنا I'm targeting all UTI in GIM service. يجيني list من الميديكال ريكورد ولا من هذا give me all the diagnosis of the GIM that admitted yesterday. So I'm gonna do BAF round for them. What I'm targeting here in the diagnosis يا عبد العزيز ايش رايك؟ I'm targeting is this people compliance with the guideline that I make it or no. صح؟ أنا لما أحط guideline للنمونيا ولا أحط ده I want to fill BAF round. I want to make sure they are compliance to cellulitis guideline ولا to the CAP ولا to the UTI. طيب مين اللي قال في واحد أسوي BAF round؟ كيف how to convey the message for the teams. يدوكيمنت في الشارت كل يوم لما تيجي في الباف راوند you have system. So which one? الباف راوند يكون by this way. So you will document باف راوند ASP باف راوند meropenem is inappropriate please DC meropenem. صح؟ Any other؟ ها؟ face to face. Usually احنا we doing ground. صراحة we sit with the ICU people and we discuss with them two times. We came at Monday and Wednesday. I will come to you. I'm plotting also KPI, what we will do in National Guard. Or face to face phone call. ساعات أكلم السيرجنت يقول لي أنا في الأو آر. Okay, you have two patients in meropenem. We don't think that this is indicated. Please DC meropenem. So we can do also by phone call, BAF round. What else? Word round, phone texting, or documentation in patient record. So this is how to document your BAF round. طيب prospective student feedback. What are the benefits? حلاوة الباف راوند إنه flexibility. Could be Monday, Wednesday, صح؟ I'm not restricted to any time. أنا بحطه Monday على Wednesday عشان ما عندي عيادة ما عندي عيادات ما عندي ذا أكون أول بي to go with that. So it's more flexible, صح؟ What else? More acceptable to the prescriber, صح؟ If I remove all prescription for the prescriber من السيرجن من الاي سي يو they will be ليه احنا ما نعرف نكتب انتبيوتيك صح؟ So it's more acceptable to the prescriber. He can write the antibiotic, but I will come to assess and to do feedback. Impact on multiple aspects صح؟ أنا لما بسوي باف راوند في الاي سي يو مع ال clinical pharmacist مع الفيلو مع الانفكشن كنترول عندي في التيمز we'll tell them that this patient is a meningitis. So you need, for example, to increase the dose of meropenem to do. So I'm targeting many part, dose, frequency. الفارماسي will review all the patient. طبعا احنا بنسوي باف راوند للاي سي يو we'll do buff round for those patients not seen by ID. خلاص اللي تشاف بالاي دي عاد ونسلم ب زي ما يقولوا ال consult حقت الاي دي. لكن usually we doing buff round for those not seen by ID. طيب loss of balloon effect ايش معناها يا اشواق؟ ايش معنى loss of balloon effect as a advantage for buff round؟ احنا نعرف restriction لا قلت لهم لا ما تكتبوا meropenem يروح يحول لك على تازوسين صح؟ منعته من التازوسين يروح يحول لك على سيفيبيب. فايش it will be squeezing the balloon يسمونها. This is the concept of squeezing the balloon. This is not there in background. What else? Recommendation more educational. دائما لما نجي احنا ASP round في يمكن حضر معنا الدكتور عبد العزيز دكتور حسين. They are happy because they want to listen. We told them, for example, Siftaz Afi is not working against the Cinetobacter to the ICU. So they will take it as a more educational also for their staff, for the resident, for the people there. Can address utilization issue throughout therapy, feasibility of the ASP with a collegial relation, no delay in the initiation of the therapy. صح؟ أبدأ, but I will come to you. So no issue with لأنه most of them يقول لك أنا I'm not starting because أنت restrict this antibiotic and now the patient died because I'm not give him, you delay on approval of this medication. So here, as a benefit, no delay of initiation therapy. And also there is also one of the important things that is not requiring 24 hour. I will come. طيب, what are the disadvantages? يوم الأحد, يوم الاثنين ويوم الأربعاء يجلس من الصباح الكلينيكال pharmacist and the fellow reviewing all the patient. So it's resource in this. Spending all the time on the medical record. They want to check, is this patient right or no? صح? Need good communication skill. Whenever the ICU people or oncology, they trust you, then they will accept what your recommendation. Otherwise, they told you, shukran. Because here, it's optional. ممكن ياخذ recommendation, ممكن يقول لك, thank you, I will continue. So it's optional here. It's not mandatory في background. صح? So compliance with the recommendation is optional. IT support, صح? We need it. And I want to see all the patients in this unit on meropenem. Every day, bring me a list. So IT will help you with that. Very important. Will give me, for example, all the patient in ICU that not seen by ID. حيطلع لي كل البيشنت اللي not seen by ID. So IT support is needed here also. Delay in addressing unnecessary empiric therapy. يعني أنا أو إحنا بنسوي راوند يوم الاثنين في الاي سي يو. طب المريض بدأ انتبيوتيك يوم الخميس الماضي. خميس جمعة سبت أحد اثنين 5 days على empiric therapy and I'm not targeting them. صح? It's one of the disadvantages. Cannot address the pre-antibiotic culture compliance. صح؟ لأنه ببدأ الانتيبيوتيك. I don't know if he sent culture for before starting antibiotic ولا لا. Difference opinion among ASP reviewer. ماهر الأحمدي يقول لك لا no need for meropenem. يجي زميلي في another ASP consultant. I think we need to continue on meropenem. في sometimes في discrepancy between the reviewer. طيب, associated metrics. سويت background. What I need to measure. This is what I need to measure, which is drug utilization, DDD, DOT, cost of all targeted antimicrobial, and I'm targeting all patients on amphoby in hematology oncology. So I will see the cost. Duration of IV, antibiotic, types of recommendation made by antimicrobial stewardship program. What you are doing, for example, we have a form in National Guard, and it will be, for example, each patient will be meropenem, for example, كان على meropenem وticacycline. So they will check the dose, the indication, the culture, all of these, and at the end, it will be appropriate or inappropriate. You can write inappropriate based that this patient has, for example, low dose. So the dose here will be inappropriate due to the dose, for example, or due to indication. So it will be come to you on these metrics. Acceptance rate. This is an example of our data in National Guard. So number of antimicrobial patient days monitored by quarter. This is we do it as a quarter base in our hospital. So this is the overall appropriateness. كان في البداية low 61 with good round, we increase it to 79 to 83, but unfortunately in the Q4 again, the appropriateness in our hospital drops again. But there is some issue with the data entry also in this quarter. This is what I mentioned about you, that indication, dose, and also frequency, duration. So you can see here, if we don't have any issue, mashallah, we have a good clinical pharmacist in ICU. So usually we don't see any issue with the dose or frequency. Most of the issue usually with the indication in the red color, or for example, also in the duration. مريض already مثلا 10 days على ميرو, it's a fab, no need only 8 days. Why I need to continue on, for example, on meropenem? So we'll have an issue here with the duration and also with the indication. Otherwise, if you see the yellow color here, which is the route, and also the green, the frequency, it's good in the assessment. Type. This is our acceptance rate by ICU. They are following our recommendation up to 68%. Because usually after we fill this form and on the next, for example, BAF round, we want to see, are they following our recommendation or no? If they're following recommendation, we say yeah. So it will be 68% of our ICU, they follow our comment and order and change of the not following in 16.4 and missing in 14.8%. Done with the BAF. Any question, the BAF? طيب, let's move to the formulary restriction. Stewardship team work closely with the B&T committee to designate a restricted drug. تمام, based on indication, based on it's requiring a pager or phone call. أكلمك الساعة 2 في الليل. I need to start patient on meropenem. Please approve it. أكلمك الساعة 3. I have Klebsiella, Oxa 48. I need approval for سفتها زعفي. صح? Phone call, pager, 24 hour, you need to be available. Each intervention is a mini consult. Success depend on what? بعض الناس توكل الله أبدأ. Start. صح؟ بعضهم لا. It will be no. Why you want to start on meropenem? So again, here it depends on who will approve for the restriction antibiotic. طيب. Same concept. This is what's called prospective to didn't feedback. A pre-authorization antibiotic prescribed by primary team. If belong to the restricted list, then it will be first few dose. بعض مثلا الجامعة, المستشفى الجامعي, they allow for 1 dose. عندنا في المستشفى we allow for للأسف 3 days. Why? ها؟ أنا أقول لك ليش. عشان ما في حد يغطي في الويكند. بصريحة. ما في on call to approve for antibiotic over weekend. So if you prescribe, for example, meropenem on Thursday afternoon, I will catch you only on Sunday morning. في other hospital مثلا زي الجامعي بيقولون يعطون first dose only. They allow. Second dose you need to call for approval. دكتور بشار, عندكم what's في another microphone يا شباب? another mic. ابغى اسمع بكل واحد restriction حقه كيف.
احنا بالنسبة لنا for 48 hours.
I want to prescribe meropenem.
Yeah.
Would be allowed for 48 hours.
لا طبعا عندنا levels of restriction. في عندنا level 1 و level 2 و level 3.
Yeah, we have it already.
Yes. For example, احنا لأن عندنا on call أمانة للآي دي, بس في نفس الوقت we do not want to overutilize لأنه يعني يصيرون over. فمثلا سفتاز دم آفي, سفتولازين, تيزوباكتام, النوفل أنتي مايكروبيال, ولا واحدة جرعة. This is not going to happen at all. meropenem جرعة واحدة, تيزوسن, سفتازدم, سيفيبايم for 48 hours, بعدين they need to call ID. طبعا احنا الدكتور يمكن less than you because احنا not an oncology or transplant service. فاحنا بالنسبه لنا تيزوسين ترى يعتبر البرفورمانس حقه كويس حتى في الانتي بايوجرام اتس جود فور giving them something that is strong. بس يمكن انتم بالنسبه لكم يعني تيزوسين is nothing because of the patient population that you're seeing.
Any other experience restriction also in بالتالي في القوات المسلحة؟
الصراحة احنا في القوات المسلحة عندنا لستة ميديكيشن ليست، فكل الميديكيشن ما تنصرف من الصيدلية إلا بالاي دي كونسلتنت ابروفل. في حتى الفيرست دوز ما عدا certain indication اللي احنا بالانديكيشن اذا كان البيشنت مثلا عنده سيبتيك شوك meningitis فيبراين نيتروبينيا and mention it في الاي او اس اللي احنا عندنا فورم اسمه اي او اس اللي هو انتي ميكروبيال اوردر شيت. فاذا كان mention this indication the pharmacy should approve and dispense the dose and the ID consultant will follow the patient and يعني بيشوف هل هو من جد right indication ولا لا.
احنا in our hospital the restriction is different between ICU and non-ICU facility. In ICU, for example, tazocin, no need for restriction. Cefepime, no need for restriction. Meropenem and ceftazidime, colistin, need for restriction. For example, no, first dose is allowed. First and second dose is allowed in ICU. In the medical ward, no. More restriction. Tazocin need first dose, no need. But starting from the second dose or third dose, no, by call, phone call, and by code. Call and we give them code. Usually they don't call after 12 because they are cooperating with us. And for nephro, ciprofloxacin is not restricted.
Two doses. Two doses.
Dose. Any other experience restriction?
almost same but for novel medications هو all antimicrobial should be revised during 48 hours except for novel medication. This one need approval from the ID consultant.
Right. Let's continue. So certain antibiotic either restricted to all, and I want to restrict meropenem to all. I want to restrict, for example, tazocin to all, or authorize for certain specialties. No, meropenem can be written by ICU, or hemato-onc can write meropenem. So certain specialty, it's okay. Authorized for certain location, again, ICU, مثلا oncology, I will let them, for example, meropenem they can write it. Also, or authorized for certain indications زي ما ذكر زميلنا. لا, for septic shock, for meningitis, or for febrile neutropenia, please approved without calling ID. طيب, level 1, دبو ذكرت الدكتور about level 1 or level 2. level 1 ايش معناه؟ restrict only only authorized physician can order. For example, احنا عندنا ال HIV medication is level 1. only ID. السفتازين تازوباكتام level 1. daptomycin level 1. بس في some medication only ID physician he can write this one. What we meaning by level 2? They need approval. So unauthorized physician can order antimicrobial only for certain period. احنا بنحط 72 hour, but it need approval because it came as a consult for ASP, and we will approve or disapprove this order. This is the table. For example, عندنا imebinam احنا level 2. يعني level 2 for what? For whom? For hematologist, infectious disease intensivist. So these specialty they can write imebinam. Let's say one, lopinavir, for example, ritonavir, fluconazole for ID service and hemato-onc. And also
has a day.
طيب again ايش الادفانتج والdisadvantage for restriction or pre-authorization? So optimize empiric antibiotic therapy, صح? Before we start the antibiotic, I will know that I will approve only for certain indications. So I will optimize the empiric therapy, because even before starting the medication, I will make sure that he has the right indication. Can result in it early and significant reduction. أنا لو سويت restriction للإمبنم والمرابنم على طول حشوف الDD والDOT decrease, because I applied restriction for this medication, provide education directly to the prescriber. He called me, this is meropenem, I want meropenem. No need for example. So it will be give also some education for the prescriber, data collection or request guideline adherence, and also approval rejection activity is generally easier with the restriction strategies. طيب ايش challenges؟ في some challenges في restriction related to approver، صح؟ اللي بيسوي اوكي ابدا زي ايش؟ يكلمني اخر الليل resource intensive، صح؟ I will need to be caring all the time my phone to approve the antibiotic. Time consuming and demanding. Effectiveness depend on the skill of the approver. Again, ماهر الأحمدي not like مثلا example عبد العزيز، صح؟ في some approve على طول يعطيه approved، بعضهم لا need to. So it again depend on the skill of the approver. في issue related to the prescriber، صح؟ ايش الissue related to prescriber؟ أنا I let them not to write any antibiotic. So loss of autonomy. This is very important. And they will try to make خاصة الاي سي يو لما تشيل منهم حاجة ولا من السيرجنت ولا من الانكولوجي، they will be defending and they want to write antibiotic, because again the same concept, we want to save our patient. So loss of autonomy and potential for prescriber to manipulate the system. هذا اللي اقول لك عليها، ياخذ الكود من واحد ثاني. ايش يسوي عندنا في المستشفى؟ يقوم يغير الكود في البيست كير، يخليه كاي دي بيرسون. فور اكزامبل ريزيدنت لما يجون يسوون روتيشن في الاي دي، they need to change the specialty. So when he's changed to the ID, he can write all the antibiotic. So when he go back, for example, to GIM or this one at night, he will change the specialty and he will write antibiotic. And it's difficult at that time to catch them. So they will manipulate to the system. Potential for patient safety issue, as I may mention. طيب هذه الissue related to the approver, to the prescriber, to the patient. ايش related to the patient? If we delay the first dose and the patient went to septic shock, we will be blamed. That because the ID not approved the first dose, or we delayed in approving the antibiotic. Like pre-authorization, what to measure? Time from initial prescription to the patient receiving antimicrobial. You want to make sure there is no delay. صح؟ من the prescribing of antibiotic إلى البيشنت أعطي الانتيبيوتيك. So there is no any delay because of the approval. And antimicrobial utilization, DDT, DOT, impact on patient, MDRO, C. diff, and workload measurement for individual عشان تاخذ manpower support if needed. So question to you guys. So which strategy would you apply? Formulary restriction, pre-authorization, or BAF? هنا يقول both. مع A ولا مع B؟ ايش رايك دكتورة؟ بعد الادفانتج والديسادفانتج اللي شرحتها. What do you think? Which one is the best strategy?
Both.
And this is, yes, all should be applied. Here in the guideline, they mention that prospective audit feedback and restriction and pre-authorization are the two most effective antibiotic stewardship intervention in hospital. And you need to apply it all if you can. And your system is allowed for that. Why both? Because in front end strategy by doing formulary restriction, I will target the immediate effect and the direct control for the antibiotic. And the BAF, I will optimize here additive effect on the DOT reduction, long-term effect, and also decrease the balloon effect. So applying both intervention is the best for any ASP program. This is the recommendation from the IDSA guideline. Again, they mention we recommend BAF and restriction over no such intervention, and it received a strong recommendation for these strategies. This is very important take-home message, especially with when you're applying both strategy. Always when you go as a BAF round, well, when we're dealing with a other specialty, you need to know how to handle the poor performing prescriber. Number one, compare the prescriber to peers within the hospital and other hospital. الآن, I can tell you from my CU round, there are some consultant writing antibiotic more than the other. Some surgeon writing antibiotic more than the other. Primary health care, if you go for any primary health care and there are 10 consultants in the primary health care, you will find the one that prescribe antibiotic more than other. So you can, in polite way, doing peer review that among the antibiotic prescribed, for example, in the last 3 months, you are the highest prescriber of the antibiotic among the other 10 مثلا consultant. So compared, this is how to handle the poor performing. Number two, understand that all prescribers have a good intention, care. هذا دائما we found it from the ICU. Our patient is sick and septic or oncology. So they want to maximize, to use the broad spectrum antibiotic. So you need to understand that all prescribers have a good intention, care, and believe they are right. Number three, get them involved in the developing joint guideline. What I mean by that? يعني 2 weeks ago, we developed a guideline, febrile neutropenia guideline. I involved 4 specialty. ID, ASP, hemato-onc, and also ICU physician. So when you engage people in guideline, for example, in febrile neutropenia guideline, in, for example, prosthetic joint infection, let the orthopedic come and sit together, because at the end, they are the one who write the antibiotic. So involve them in the joint guideline and keep coming back, but without being defensive. Sometimes انتم تكونوا متحمسين في الاي اس بي background ولا متعصبين. You need to stop it. No. Sometimes we need to be and to have a good communication and build a good communication. Otherwise, it will be go back and fire back in the program. Again, prospective monitoring and direct feedback in the real time if needed, and escalate. If you see that with repetitive measures still they are, you need to escalate to more يعني administrator or a senior staff. طيب, take home message, both interventions should be prioritized for implementation. Pre-authorization can help optimize the initiation of the antibiotic, while BAF can help optimize the continued phase of the antibiotic. Local data knowledge of the practice determine which antibiotic subject to prospective feedback or to the pre-authorization. Question. BAF restriction. ناخذ بريك 5 minutes ولا تبغانا ها؟ ايش رايكم؟ بريك 5 minutes ولا 10 minutes؟ Any other question? طيب, we'll be back at ها؟ طيب, 11 10:55. يلا يعطيكم العافيه, شكرا.
We will continue now with the last part of our workshop. I'll talk about ASP in special patient population. وحنتكلم شوية عن ال OPAT services. وبعد كذا إن شاء الله بنختم مع دكتور ماهر. طبعا يمكن قبل شوي we talked about إنه there are different practices based on the patient population that we are tackling. So you've seen that the practice Dr. Maher they have in National Guard is different than, for example, the practice we're doing because we're at university hospitals, because we have different patient population. So of course, when we are talking about antimicrobial stewardship in oncology patient, transplant patient, it's different than general patient population. It's different than critical patients as well. Why do you think these patient population are different? So for example, oncology patients, what makes them special in terms of antimicrobial? Excellent. Yes. So they are on prophylactic antibiotics that might lead to increased rate of resistance. They have repeated admission. They're on high-dose myelosuppressive agents that make them highly immunocompromised, susceptible to different bugs and pathogens as well. So when you're talking about stewardship in those patient population, you will find people are hesitant to de-escalate or to do the activities that we were talking about. Second. Yes, thank you. So you're going to find that people are hesitant to de-escalate. Nevertheless, the use of antimicrobial in oncology patients, it's high because they are exposed to prophylactic antibiotics. They are exposed to other factors. For example, they have neutropenia that might predispose them for different type of infection. So we need to balance whether we're giving effective antimicrobial therapy and at the same time we are practicing the principles that we talked about in antimicrobial stewardship. So the thing that will make or break an antimicrobial stewardship program is always listen to the other people's concerns. So when you're talking to a hematologist or oncologist, you need to talk their language. They do not, again, what Dr. Maher said, they do not want to misuse antibiotic, but they have sick patients that they know that they might be exposed to multi-drug resistant pathogens. So they might be hesitant towards de-escalation or even narrowing the spectrum, discontinuing unnecessary antibiotics. So these patient population, it's better to do the pre-authorization and prospective audit and feedback rather than just pre-authorization, because you want to have this conversation, you want to monitor the patient, you want to feel that they are engaged in the decision-making of antimicrobial stewardship program. So we know that ASP has demonstrated effectiveness in general patient population. So how about in the oncology patients? In oncology patients, we would have the challenge of complexity of the cases, also the challenge of difficulty with acutely diagnosing the patient in a timely manner, and also the high risk of mortality related to invasive infection. At the same time, you want to not misuse antibiotics so you don't get the cycle of also exposing them to MDROs. All of the societies, whether it's the IDSA Society, whether it's the Pediatric Infectious Disease Society, all of them do support using antimicrobial stewardship principles in all patient population, including immunocompromised or oncology patients as well. Of course, there are different modules that we can apply to patients who are immunocompromised. We can do pre-authorization. However, it's better to do prospective audit and feedback to get them engaged in the decision making process. Antifungal stewardship is one of the things that also increasingly being used in oncology patients. Having clinical guidelines, pathways, the pathways Dr. Maher talked about, having febrile neutropenia clinical pathway that is getting everyone involved in writing is also one of the important aspects of ASP, de-escalation and discontinuation of antibiotics whenever we do have a diagnosis and cultures. So one of the things that we would want to utilize as well is evidence. So when a person tells me there is an increased rate of mortality in de-escalating antibiotic in oncology patients, I'm concerned about the high risk of recurrent infection in those patients. So we want to go back and look at the evidence. There's evidence supporting using different modalities in those patients. So if you go, you would find in the literature a lot of studies that looked mainly into prospective audit and feedback. And prospective audit and feedback have actually led to better outcomes in terms of DOT, DDDs, and did not negatively affected the clinical outcomes such as mortality or cure. So always try to share these type of studies and information to oncologists, hematologists, to make them more comfortable into getting enthusiastic about antimicrobial stewardship. So there are other things that we can do as well, such as pre-authorization of meropenem, restriction. But as Dr. Maher said, restriction will not lead to this conversation, this healthy conversation, to change in practice, to educating the staff as well. But even pre-authorization have been also reported in the literature to have a positive impact on hematology patients. So how about the ICU? Do you think the ICU face the same issue with antimicrobial stewardship? Is there resistance? Yes, no? Okay, so surprisingly, yes. So if we're going to look at statistics, which area antibiotics is prescribed the most in a hospital setting, it would be ICU. Of course, if we're talking about broad spectrum antimicrobials. So they have the highest rate of consumption, and this is justifiable because of the patient condition. Patient are septic, in septic shock, patient, so there is a reason for that. But however, we can optimize the use of antimicrobial in this patient population. And always you would see hospitals that have pre-authorization try to put limits to ICUs to get antibiotic. As you've said in your practice, you might give ICUs a dose or two because of the nature of the patients. But also prospective audit and feedback is very much important within the ICU to keep them also engaged and to keep them enthusiastic and also accepting of antimicrobial stewardship. So this is actually a study that is published recently in 2023 that looked into a pathway on how to do, let's say, prospective audit and feedback in patients who are critically ill. So they developed like a pathway or a steps to approach ICU patients. So it starts with whenever we're suspecting a bacterial infection in ICU patient, it's either can be sepsis or it can be septic shock in some cases. So we will start empirical therapy. Of course, empirical therapy, it could be a combination, especially when we're talking about septic shock patients, or it can be single agent. They are recommending to use non-carbapenem in case of there is no risk of the patient of colonization, clinical history, rapid resistant testing. In case we used carbapenem, then at day 1 and day 2, we need to re-evaluate what we've chosen, whether we've chosen combination or we've chosen carbapenem-based regimen, then we need to re-evaluate. Re-evaluation is based on the cultures that they're going to come back to us, the resistant testing that we've requested, the imaging that we've requested. So then we would switch and narrow by day 3 once we have a definitive treatment. And usually by day 7, we need to evaluate the duration of therapy because most of these infections can be treated within 7 days. So by day 7, we need to have a plan for when to discontinue antibiotics. And this is one of the things that in the ICU usually we miss. We keep the patient on antibiotics until he's discharged from the ICU, and this is a wrong practice that increases the risk of resistance. Okay, so how about outpatient settings? So Dr. Maher mentioned that we need to do antimicrobial stewardship in the outpatient. It's still one of these areas where we don't know how to tackle because it's very difficult. There are different things that we need to control, and sometimes it's not in our hands. So how many of you have antimicrobial stewardship in the outpatient? None? Yes. So because it's we are now like mastering the hospital ASP. We know what works, what doesn't, what team can we use, what is the metrics that we can do. However, we still have like lack of knowledge in terms of ASP and outpatients because of lack of experience. But I'm sure like a couple of years from now, we will get there, especially that a lot of the accreditation bodies are stressing on having an ASP program in the outpatient. The problem with ASP in the outpatient that we don't know where to start, right? So always when we want to start something new, we always try to choose something that is easily achievable and measurable, so we can at least get the wheel moving. So if we would see, this is something that they looked at, a review that looked at different studies. They've included 15 studies, and they've seen that the most methodology of ASP was indication of antimicrobial prescriptions. That was the most type of intervention they used, and they've seen that there was an improvement in antibiotic prescribing once ASP was started. So it starts similar to the hospital ASP when we're looking at indication as the first indicator. What else can we do in the outpatients other than antimicrobial prescribing, which is something that is very much important to look at the decision to prescribe, the selection. Also, we can look at duration for these prescription as well. Guideline compliance similar to what we do in the hospital setting. Secondary outcome, we can look at patient-centered outcomes, how many clinical visits they came, how much of these patients were admitted to the hospital, and adverse event, patient satisfaction as well, microbial outcomes such as resistant in the outpatient setting. And of course, as usual, we look at cost reduction as well. Of course, these are things that we usually, what do they recommend is to choose something that is easy to be measured in your institution, easy to be done, and then try to measure and monitor these outcomes. Start from a point, and then you can find other areas that you can improve, because you wouldn't know what exactly the best intervention if you don't know the pattern of prescription, the pattern of behavior of the outpatient prescribing. The other thing is that we can do in the outpatient is an OPAT program, right? OPAT, yes. So how many of you does have an OPAT program at your hospital? Excellent. So is it an OPAT that is a facility that they come to home, infusion center or home infusion or self-OPAT? So similar to an infusion center. Excellent. Anyone else has an OPAT? Yes. So what do you do in the OPAT? Home infusion, infusion center or self-OPAT? Infusion center, okay. Infusion centers are one of the things that usually is the traditional mode of OPAT services, where the patient comes to take IV antibiotics. Of course, number one, we need to make sure that he cannot be switched to oral, This is part of stewardship, right? So if he cannot be switched to oral for any reason, either the type of infection, either it's resistant, the pathogen to oral options, or the outcomes are better with IV therapy, then okay, so this is the first step of eligibility. However, there are different modes of delivering OPAT. We have the infusion centers that you've talked about. We have home infusion center, which the nurse comes to the patient at home. The problem with infusion centers is that we're still kind of exposing the patient to a hospital setting. In addition, if he's living in an area where he's not like close to the hospital, this is a problem for him commuting. Also, if he's taking twice a day, 3 times a day antibiotics, I cannot switch him to once daily, then this is also another problem for him. And this is why the idea of self-OPAT came from. Self-OPAT, it means that the patient at home, he's gonna give himself antibiotics. Do you think this is something easy to be done, not easy? Is there any problems with this? Yes, exactly. You need a process that is built in to start from a proper selection to education to monitoring, because sometimes I might discharge the patient with any other, it's similar to other medications. He's discharged on OPAT, however, he's not taking the pumps, and then he comes back with reinfection, with relapse, then I saved no money. I increased his risk of resistance. I didn't accomplish anything. So with self-OPAT, there has to be a system and a clear pathway for self-OPAT. At our hospital, we do have self-OPAT. We do have an infusion center. However, we utilize it for infliximab, for chemotherapy. If we have a patient who's an IV antibiotic, then we discharge him on self-OPAT. And I'll try to explain for you how does it work, what exactly do we do to monitor this service. So factors that promote OPAT, which is increased prevalence of antimicrobial resistant, hospital-acquired infection. The longer the patient stays in the hospital, the higher risk of him getting another type of infection. Also, hospitalization-related costs. I want to reduce the length of stay so I can reduce the cost. Also, I can utilize this bed for another patient that might needs it. And also sometimes patient preference as well, to go back to his normal daily activity other than sitting in the hospital just to receive IV antibiotics. So we've established there are different modules. We have infusion center, skilled nurse facility, home-based, which is the self-OPAT that we're going to talk about. All of the evidence support utilizing an OPAT program. However, having a structured way to monitor the patient and to ensure that the patient is following up with his doses. Similar to patients who are admitted to the hospital, I need to make sure if the patient is having an adverse drug reaction from the antimicrobial, then I should also follow up with this. So if let's say I'm discharging the patient on vancomycin for 2 weeks as OPAT or self-OPAT, what do I need to monitor? Yes, exactly. So clinical response, this is one of the things, excellent. Yes, so I need to order labs. So I have to monitor renal function. I have to monitor vancomycin levels. So even these monitoring plan has to be addressed in the policy of OPAT. When does the patient comes back to take his labs? So this is something that is very much important, because hospitalized patient, we know we have our own protocol. They are monitored. However, we do not discharge them and then expect that they're okay. We have to know when exactly do they come to take their labs. So always, if you're trying to do an OPAT service or an OPAT OPAT guidelines at your hospital, make sure that you do have an OPAT team similar to the ASP team. They can be the same, or they can be different in terms of you would need someone to coordinate the care of the patient as well. So someone to communicate with the patient, to follow up with his appointment to check clinical cure with his appointment to take the necessary labs as well. So usually the perfect team would consist of one physician, a nurse to take care of the infusion part and take care of the cannula, pharmacist, advanced practice provider as well. So have any one of you seen the Self-O-Pat, the disposable pumps? No, of course, we're not going to discharge the patient on vials, right? Because we do not want, this is like a source of error. If I'm going to give him, for example, meropenem vial and I want him at home to dissolve it and prepare it and give himself, this is not going to work, right? So the thing is, we should try to make it as easy as possible for the patient and to reduce the error that might happen. So usually what we do, this is called elastometric pump. As you can see from the inside, it's a balloon that we fill it with the medication, with the IV medication, under septic technique under the hood. So it's filled, let's say, with meropenem or peptazole or vancomycin. And then there is a stability for each of these antibiotics inside the pump. The stability is based on data on how long does it get degraded inside this pump. So usually, for example, meropenem, it's stable for 3 days, ceftriaxone is stable for 7 days under fridge. So we need to make sure that we explain to the patient, you need to refrigerate these pumps, and then whenever you want to use them, you take them out and use them and then discard them. So they are filled with the dose that he's going to use at that time. So he use it and then discard it. So he doesn't need to prepare anything. This is important to reduce error. So it's infused over an hour, and whenever it's infused, it's going to shrink. So this balloon is going to decrease in size until it's shrinked completely, and then he can discard this pump.
Dr.
Yes.
Mashahar,
تفضل.
this is very interesting, by the way. We just, I think, start the disposable one like this month, to be honest with you, in National Guard Hospital. So my question to you, because in the beginning, we decide that each day, home health care, they go there and they provide the dose for the patient. And he will, يعني, يركبها بنفسه and he will start. But how you will give 3 doses, or what you will give for 3 days for the patient in your center?
Excellent. So this is very much interesting. You see the different level of cares we do have. So they have home infusion nurses that they go to the patient at home. We do not have this luxury. However, he can do it by himself, by the way. The thing is, you need to educate the patient very properly about the use. This comes with the proper selection. So you do not want to select a patient that he's having cognitive abilities or he's not willing to do it. So start from the selection. So we select patients who either is competent enough to give himself, or he has a caregiver that can help him with that. So what we do is we put a cannula. By the nurse, she puts the cannula, and it's there for 7 days, and then he will change it every.
Not big line.
No, a cannula peripherally, and then at the hospital we teach him how to plug. It's very simple to plug this pump on the cannula, and we need to teach him about septic technique, how to handle it, how to disinfect the area before and after. And after that, we need to make him take the first dose in the hospital. So God forbid if he has allergy or anything, we can manage this, and also to make sure that he understood what we explained for him. So he needs to take the first dose. If he is comfortable enough, we've monitored him while he's giving himself this pump. It's just like plugging it and taking it off, then he's good to go, and then he would come just for his refill every 3 days or every 7 days. And sometimes he doesn't need to come back. We can send it to him through home delivery. If in case, yes, depending on the stability. So let's say it's meropenem, then it's stable for 3 days, then we're going to give him for 3 days. Let's say he's discharged on ceftriaxone, which is stable for 7 days. We're going to give him the full 7-day supply, and he needs to keep it in the refrigerator. So this is reducing cost on us, reducing his also length of hospital stay, and we had a good success. We've started this actually 2 years ago, so now we're in our second year. But again, you need to have a selection criteria that is very much important at the beginning to ensure that the patient is not set for failure. The other thing is you need to monitor him. So because we're sending him home, we need to monitor him. So do you think, how would we make sure that the patient is taking the pumps? So they're making sure by giving him his home visits and giving him the medication. But for us, we're trusting that he's going to take it. So do you think there are things that we can help in making sure that he's taking it? Yes? Phone calls, yeah. So this is, again, we need people, manpower to do these phone calls. But this is one of the things. We try to develop something that helped us a little in reducing the number of calls we're calling the patient in. So we add a barcode on each of these pumps. And we've asked the patient, whenever you give yourself this pump, scan the barcode, and the barcode comes with did you receive the medication today? And it comes to us in our system. So when we see it, okay, we're fine. When we see that he didn't scan the code, not necessarily he didn't take it, maybe he forgot to scan it, but at least then he will get the call. This will reduce that the patient will come with reinfection because he's not taking the medication. So we've established that these elastometric pump, they're not electronic. They work with pressure. So this this balloon will slowly administer the medication through the cannula. So this answers your question, Doctor. We put for him a peripheral cannula, and then we make sure that the first dose that the patient is taking is at the hospital to see and test his technique, and if everything is fine, then he gets
Is it
discharged.
specific type of cannula? Because usually the system in National Guard, they not allow for cannula more than, again, like more than 48 hours.
Yes.
They need to reinsert another cannula.
Yes. So, so this is very interesting question. This is when we started, that was a huge fight with the nursing department because hospitalized patients, 48 hours, and then we need to change the cannula. However, we've looked at evidence, we've looked at other people practices, and we found that we can use it up to 7 days and then we switch. So let's say if the patient, we've discharged him on meropenem, which he will come back to collect the pumps, then we can also change the cannula earlier if possible. It depends on the patient and where is he located and whether he's going to come or not. But it was a huge fight at the beginning to really discharge. By the way, the cannula, there's a lot of problems that can come with it. There can be bleeding, there can be occlusion, there can be a lot of things. This is something that we also need to take care of. So the patient can be not taking his medication because he has a malfunction in the cannula. And this is something we need to catch if he doesn't scan the codes. Then he needs to come to the emergency and we would look at the cannula and change it if necessary.
Yeah, this is very important. When you introduce the such like the system, so during the troubleshooting, for example, patient, for example, he's not receiving the dose, or there is a problem with the cannula, what they need? Is there like a phone call, or is it just to direct him to the ER?
Okay, so we do have, I'll show you now, just a second. I'll show you it. So we do have, not this one. Okay, so we do have a number that that is a hot number, a WhatsApp number that they can write at any time if they have any issues. Beside the barcode that they will scan and then it will come to us, did you take your medication today? Do you have any problems with it? Also, he can access us if he has any issues with his medication, if he feels that he's having an adverse drug reaction, if he has a problem with his cannula, then he can call he can text, let's say, the number, and then we can tell him what to do. The other thing is, what would he do? Every patient who's discharged, we need to give him a card that he's discharged on this cannula. Because if we tell him, go to the emergency, then they need to know what exactly is he asking for. Because we face this, that when we started the program, a lot of people, they don't know about it, despite our attempts to talk about it. So if they don't know, they would say like, what do I do? And then the patient gets even more confused. So we've developed this card to make sure that they know that this is something that we prescribe. So if the ER physician is not aware of it, then he can give us a call and what exactly is this, what do you want from me? And if if it's during hours, then he doesn't need to go to the ER. We have an infusion center during hours and weekdays. So we can change the cannula, we can address his problems in the infusion center. If it's in the weekend or after hours, then he can use the cards to go to the ER. And usually we take a step ahead of him and we talk to the ER to tell them what to do exactly. So this is why it's very important to have the system of monitoring the patient, because anything can happen at any point, whether it's an adverse drug reaction from the patient or from the medication, or from the cannula, or a compliance issue. So this is very much important to do. And that's why stewardship needs support, because you need manpower to do these things. So what we do, I've mentioned that we do have a team that have a specialized ID physician, ID pharmacist, health educator. They were with us at the beginning of the project, and now we're actually doing it through our residents. So, usually we do not have the health educator. It was just at the beginning of our project. And then we have an eligibility criteria, which the ASP program agreed on. So who are the patients that can be discharged on this service? The first thing we ask ourselves, why not oral, right? So we don't get excited about having an OPAT patient. We want to make sure that there is exactly an indication for IV therapy over oral therapy. So any patient who meets the eligibility criteria, then we sign him on informed consent. The reason we are doing this consent, just to make sure that the patient understands the risk of this of getting discharged on this OPAT, so he would be more vigilant about the side effects that he might get. So we do explain for him what exactly could happen with the use of self-OPAT, without scaring him, of course, but to explain for him exactly what can happen. And if he refuses, by the way, to sign the consent, and if he refuses to get discharged, this is his right. So we do not discharge him on self-OPAT. So let's say if the order was done and then the patient processing the order by the OPAT team, we do not discharge a patient on 1 day of OPAT. Usually it has to be minimum of 2 days. And this is something that is also mentioned in the IDSA guidelines. We do not discharge patients who refuse to sign on the consent, and we do not discharge patients who are pregnant because of lack of evidence in this patient population. So as I've mentioned, we go and explain either to the patient, either to the caregiver, and the first dose he has to take it in the hospital by himself. So he needs to plug the self-OPAT, he needs to check when is it finished and then discard it, and then also apply septic techniques. So we measure all of these during the education session. And also we do provide them with a booklet that they can go back and understand, how do I open it, how do I plug it, what are the side effects of it. So because sometimes patients would forget, and it's good to have this as an information for him. And as I've mentioned, we also use the card to identify the patient if he's coming either to the infusion center or to the ER. We've also created a list of monitoring. So if the patient is discharged, let's say on ertapenem, then we need at least once a week CBC, basic metabolic profile, and liver function test. And this is our process of making sure that we've ordered all the labs that is required from each medication. Also, we've created a patient satisfaction survey because at the end of the day, we want to take into account how is the patient experience. By the way, the patient satisfaction survey led to a lot of improvement in our process. One of them is creating the card. Because during the satisfaction survey, they've mentioned, I went to the ER, nobody knows exactly what am I on, what is this? So sometimes hearing from people would improve your process. So it's very much important, especially when you're beginning a service, to listen from people and take their feedback, because it might change a lot of your practice. So we do give them a call by the end of the treatment, and we ask them. We send it as a code. If they do not answer it, then we give them a call and ask them about it. So we have recruited 60 patients till date. It's not a huge number, but because we have a restricted criteria of selection, and many of our consults is actually an opportunity for stewardship to switch to oral. So sometimes they do call us for self-OPAT, and we can, by the help of ASP, to switch to oral medication. But whenever it's necessary and the patient does sign the consent and all of the other factors are taken into account, then we can discharge them. So we had 60 patients, with most of them having less than 7 days of duration, and 90% of them completed the therapy. Some of them, they felt not comfortable with the self-OPAT, so they required hospital admission. And some of them faced difficulties with their cannula as well. Alhamdulillah, we didn't have any mortalities. However, the clinical cure was 86% of the patient, and this is a good number. Look, taken into consideration, it's not all about the OPAT itself. There are other factors that might contribute to clinical cure, the choice of antimicrobial, and the compliance as well. 30-day readmission rate, we had 8.5. They were readmitted. 20% have experienced side effects, and we end up saving around 1,003,000 on just length of hospital stay in those patients. And we had a good, actually, patient satisfaction of 82%. By the way, patient satisfaction comes when they feel they are monitored. So because they feel that we are trying to reach out to them, their satisfaction actually increased. So this is the end of my part. If you have any question before Dr. Maher starts.
I have a question.
تفضل.
Which antibiotic you discharge the patient on? Self-OPAT.
Okay.
Example, other than ceftriaxone.
Okay, so we have established a list. The list is based on multiple factors. First of all, stability data, because some antibiotics, by the way, are not stable in the self-OPAT or the pump, or we don't have data on it. For example, I'll give you an example. Amphotericin B, we don't have data on it. So this is for sure, this is something we cannot use in self-OPAT. We've created a list, and we've excluded vancomycin and aminoglycosides because though we have stability data, but we've excluded it because we do not want to deal with the levels at home, because we thought this might complex the situation and let the patient come back and forth. And we know with the levels, while they're hospitalized, we're facing issues. So usually patient on vancomycin, this is our practice, but it's not every place practice. So we do not discharge on vancomycin and aminoglycoside. What we discharge on, ceftriaxone, meropenem, ertapenem, cefepime, ceftazidime, clindamycin, surprisingly, though it has excellent oral bioavailability, but some patients were eligible for it. Yes, I think cefazolin as well.
أهنيكم. Excellent program صراحة. Now in National Guard we have 3 programs. We can ask the patient to come to the clinic one to receive the daily dose, so only 1 dose. So we can recruit like up to 5 patients in the outpatient clinic. So they need to travel from their home to the hospital. In the clinic one, they receive 1 dose only. The second program that we have it, which is no, we're able to have 2 doses. We send the home healthcare department to the patient. They can give 2 doses only. لكن عندنا إشكالية. أخذين بس 30 كيلومتر around the national guard. لما تيجي تاخذ 30 كيلو من الحرس حدك شارع فلسطين. Most of our patients فين؟ بأبحر مثلا في. But this is some of the struggle that we have it. A third, as he mentioned by Dr. Bashar, we start like 2 months ago, we create all the policy for the self-administered اللي هو antibiotic pump. I hope إن شاء الله we recruit 2 till now, مو 63 ما شاء الله, لكن أهنيكم على البروجرام هذا. All the best. طيب, مسك الختام. Very important topic. I'm going to present it now, which is how to do collaboration between antimicrobial stewardship and the microbiology. So let's start. معنا دكتورة مها علاوي هنا كمان الهيد حق الميكروبيولوجي يعني. طيب. So what's the objective for my presentation? We're going to discuss what are the IDSA guidelines related to the microlab and explain how diagnostic stewardship enhance antimicrobial stewardship, and also what's the ASP role for the rapid diagnostic test. Is there a role that should be initiated by antimicrobial stewardship, and rapid diagnostic test available? Which test? How to implement it? لو رحتوا الاكسبيشن هنا يمكن الظاهر 4 or 5 company, each one has a rapid diagnostic test. So we need to choose one. What's the ASP role? So let's start. So the key concept in the field of infectious disease is what? Organism identification. I need to identify the organism so I can optimize my treatment, especially when the first few hours of the sepsis recognition is critical. So this is the famous or landmark study published that they mentioned by Kumar. This is what he writes, the sepsis guideline. They mentioned that each hour of delay over the first 6 hours resulting in 7.6% decrease in the survival. This study illustrates the importance of the concept, what? Getting it right upfront about the empiric therapy. So culture before antibiotic, يعني you want to shock any ID physician or any that, don't do a culture. أبدأ ولا تبدأ and ask the ID to come and de-escalate or ask the ID to stop the antibiotic. Surgical approach بتقول هنا. So more difficult to de-escalate therapy without culture, and again don't delay therapy. So what's the lab method? Traditional way, what we do now, standard technique, which is for identification of organism based on what? Phenotypic method, which is requiring 48 to 72 hours to provide final culture result, compared with a rapid diagnostic test, which can provide final result within hours, compared to the technique, the traditional culture phenotypic type. So rapid diagnostic tests test a wide range of pathogen causing bloodstream infection, central nervous system infection, respiratory tract infection, gastrointestinal. You will hear about what's called syndromic approach. So patient came with a respiratory illness, I will do rapid diagnostic test for the respiratory illness. Or patient came with a diarrhea, GI symptoms, I will do rapid diagnostic test, for example, for a GI. Antimicrobial resistant joint infection. If you have like septic arthritis, by rapid diagnostic test, you can be able to have a result within 1 hour. So can distinguish between viral and bacterial infection. And also, so this is one of the example for rapid diagnostic test, like 43 target from blood culture can be targeted. So yani what organism that can be not found in this organism? So by rapid diagnostic test, you will be able to detect the most common cause of bacteremia, candidemia, either by gram or gram negative, gram positive. So this is the example for that. This is like a 43 target can be detected by rapid diagnostic test. Imagine even for gram negative, all the enterobacterias, and able to detect antibiotic resistant like what? Like MIC-A for MRSA, fan like VRE, for example, or carbapenemase, by only one single test, you will be able to have the result within 1 hour. This is an example of the respiratory organism, for example, that can be detected by the rapid diagnostic test. All the possible cause of respiratory illness can be detected, including virus, bacteria. Also in the GI panel, you can detect bacteria, parasitic, and also viruses. Now, there are advanced even the rapid diagnostic test. You will be able to have within, rather than to wait for a culture to come after 72 hours or 7 days, within 1 hour, you will send the joint synovial fluid and you will be able to do or to detect as a most common of these organisms that commonly cause joint infection or commonly cause CNS infection. So a lot of rapid diagnostic tests available nowadays in the market. There is for the most common resistant gene for MIC-A, MIC-C, for MRSA, as I told you, FAN, for VRE, ESPL, RBOP gene mutation. Before, when we have a patient that AFP positive, let's say AFP, and we start the patient on anti-TB, so we need to wait how many days till the culture came back or sensitivity to come back? 2 months. 2 months, I'm waiting for the result to come back to me that all rifampin, INH, pyrazinamide is sensitive. While with a rapid diagnostic test, directly from the sample, I will be able to have, for example, resistant to rifampicin. So why I need to keep patient on rifampicin for 2 months while I have like gene expert or rifampicin resistant within 1 hour of the AFP result. Other like INHA, CAT-G also can detect mutation in INH. In addition to, this is the most common, the CARBAR, which is also can detect. So all of these is a rapid diagnostic test. One of the limitation for that, it's limited and predetermined to the organism. I will explain that. So rapid diagnostic tests decrease the time to the identification of the organism, allow appropriate antibiotic, de-escalation. Why I need to keep for a patient, for example, on vancomycin, it's a gram-negative in the blood. Why I need to keep vanco for 3 more days or 5 more days? So allow me to de-escalation of the empiric therapy, facilitate de-escalation, prevent the use of unnecessary antibiotic, and decrease antimicrobial resistance. So what's the IDSA guideline or ASP guideline that related to the rapid diagnostic test? 2 recommendations from the IDSA guideline and the ASP regarding the rapid diagnostic test for bloodstream infection and for the respiratory infection. So for the bloodstream infection, they recommend here, we suggest rapid diagnostic test. In addition, this is very important, to conventional culture and routine reporting on the blood culture if combined with the ASP activities. This is very crucial, by the way. So what's the concept of the rapid diagnostic test? Usually when the patient came to you in the ER and you did the blood culture for him, so it will be incubated in the microbiology. Then after that, it will be announced by the machine that there is a positive blood culture. So what will be the first step by microbiology technician? What they will do? Gram stain. And they will call you, we have a gram-negative bacilli in the blood. That's it. Any idea what? No, you need to wait for another 24 hours or 48 hours because as a next step, they will do culture to wait another 24 hours to have the ID. By the way, the ID, it will tell you the next day after 48 hours, it's Pseudomonas in the blood. But again, you don't have any sensitivity or while by rapid diagnostic test, you will have the answer within 1 hour. You will have pathogen ID within 1 hour. If you have a blood culture positive and the gram stain gram, for example, let's say gram-negative bacilli, by applying the rapid diagnostic test, it will tell you, for example, it's an E. coli ESPL within 1 hour, rather than to wait for 24 to 72 hours to have the full susceptibility testing. So this is the concept of the rapid diagnostic test. This is an example for a patient, you have a detected, for example, enterobacteriase, you have Klebsiella pneumoniae, and you have detected KBC within 1 hour of gram stain. So let's continue. Again, this is the same concept. With doing PCR, you will have a result within 1 hour of the positive blood culture. So RDT, which is the rapid diagnostic, demonstrated the benefit when by enabling timely antimicrobial to decrease mortality and also shortens the hospital stay and also lower the hospitalization cost. So rapid microbiological test will be the game changer in the future. So disadvantage, expensive. If I want to do one of these tests, it costs me 800 riyal for one test. If I want to do, for example, a respiratory test, rapid diagnostic test, 800 or 600. Is it cost effective? Is it will discontinue the antibiotic? So if you study about cost effectiveness, few implementation strategy related to maximize value and risk of contamination, you are dealing with molecular testing and also need a DNA, RNA free area and cannot indicate the viability of the organism. As same concept with COVID. It will be stay COVID for 3 months, but we don't know, is it a live organism or? So again, it cannot be just to indicate the viability of the pathogen. So this is the type of the RDT. We have the BNA fish, which is using, for example, this is the concept for BNA fish, for example. If you have a positive blood culture, you have 2 probe using for Staph aureus or Coagulase negative, and then they need electron or microscope to tell you, is that Staph aureus or Coagulase negative? This is one of the RDT, PCR, like Gene Expert, like film array, turnaround time 60 hours, nucleic acid. This is an Malditov. Malditov, we have it. It can tell you it's a Pseudomonas, but it cannot tell me what. It cannot tell you about resistance. Is it resistant or not? It can give you ID. It's Klebsiella pneumoniae, but it cannot tell you what is it resistant or not. So this is the type of the RDT that we all of these, by the way, we have it in National Guard. I'm sure in King Faisal and in University Hospital, they have all of these rapid diagnostic tests. So this is the target for each RDT. I will go quickly on it because we have like an exercise at the end. So for bloodstream infection, allow clinician to target antimicrobial therapy in more rapid manner, which can improve clinical outcome. Let's move to rapid to respiratory, the second guideline related to the respiratory illness. What they mentioned. They mentioned we suggest the use of rapid viral testing for respiratory pathogen to reduce the use of inappropriate antibiotic. Again, they recommend the rapid diagnostic test for viral illness. So RDT for respiratory infection, largely absent. ما هي زي البلاد، ما هي زي الأذر joint. ليش؟ They found only one randomized trial. Only it's important when the influenza is the pathogen. يعني 2 days ago, I have a patient in ICU and they did pneumonia panel and it came back rhinovirus. Are you going to stop antibiotic? And patient sick if I too high. So that's why it's sometimes largely absent on these type of the organism. And we need to be careful when we interpret this rapid diagnostic test. So how the collaboration between microbiology and ASP? It's a good opportunity. If you take home message, this slide, it's very important for you. So the concept here, if you have a patient, after clinical evaluation, you will do what's called the diagnostic stewardship, right test. أقول الاي سي يو يقول لك دو سبتك سكرينينج كل حاجه ويطلع لك يورين بوزيتيف اسينيتوباكتر ويطلع لك السبيوتم سيدوموناس ويطلع لك هذا. ف you need to have the right test. Very important. Same concept for any patient came to the general internal medicine يقول لك do septic screen from everywhere. طب اليورين طلعت بوزيتيف ده الconfusion not because of the UTI. So you need to be careful about interpretation of these tests. So here where you apply the rapid diagnostic test, then it will go to the microbiology lab, performed, then the rapid diagnostic test report came back, then here where is the antimicrobial stewardship program could have input about the right interpretation, right antimicrobial, and the right time. So I'm gonna skip this one. This is another important slide about the core element. We have a core element for ASP. Now we have core element for rapid diagnostic test with the ASP. What's a core element for that? So you need to have a leadership support, financial support for RDT. You need to convince that I need the rapid diagnostic test because I'm gonna decrease, for example, the length of stay in my hospital. I'm gonna decrease the cost for your hospital by applying rapid diagnostic test. So you need a leadership support, accountability by physician leader, RDT into clinical practice, drug expertise by pharmacists, and the role of the clinical pharmacist is crucial, like audit and feedback on the RDT result, action on specific intervention, especially the turnaround time to improve the antibiotic use, tracking and monitoring of these results, and how to optimize the result of these RDT, and reporting information to staff. How to, one of the, you want to have a result for rapid diagnostic test that it's a good language and not confusing for the staff. يعني المادة توف لما جبناه كان بيطلع اسماء احنا كايدين يمكن كانت نقول what is this organism. So you need to have a clear what to mention and what to report from to the teams, and also education to the provider. We have a rapid diagnostics and you need to aware about how to use it and what are the indications to use this rapid diagnostic test. This is the effectiveness. The rapid diagnostic test with the antimicrobial stewardship, when they combine together, it will lead to optimization of the antibiotic and the benefit of this program. So I'm gonna go quick. This is one of the studies that published in 2017 about the effect of molecular rapid diagnostic test on the clinical outcome of bloodstream infection, a systematic review and meta-analysis. So they 31 studies, more than 5,920 patients with a bloodstream infection and the use of molecular rapid diagnostic test. And they apply the type of rapid molecular test here, which is Malditov, PCR, and BNFH. They found the benefit of the rapid diagnostic test when they combined with the ASP, specifically in, and this is statistically significant toward or in favor of rapid diagnostic test, especially when you combine the rapid diagnostic test with the ASP. So here, the rapid diagnostic test without ASP, you can see still crossing the line. Type. The benefit when you combine the rapid diagnostic test with the ASP, in which part? They do sub-analysis and they found the majority of benefit in the gram-negative organism. All of these toward, but when you came to the gram-negative, it's not crossing the line. What is the benefit of the rapid diagnostic test? Let's go in 5 minutes. Quick exercise. So which RD test لو قالوا لك دحين يا أشواق بنجيب rapid diagnostic test in your hospital, based on what I will choose the rapid diagnostic test in my hospital. يعني الحين زي ما قلت لكم لو طلعتوا برا يمكن 4 companies كلها عندها rapid diagnostic test. طب أنا أختار based on what?
patient population. Yeah. الديزيز اللي أنا أشوفها.
إيش ممكن تفيدني دكتورة مها؟ أقول لها أعطيني مثلا إيش before I implementing like this or before I choose. I need to have like based on the prevalent or problematic organism. أنا في المستشفى الحرس الوطني أنا بعاني من جرام نيجاتيف. ممكن القوات المسلحة لاحظت سويت لو كم قبل 2019 كان كلهم جرام بوزيتيف بكتيريميا. صح؟ كان مثلا عندهم بكتيريميا كثير with gram positive. So you know your organism, you are dealing with which problem. I have gram negative, you have gram positive, you have pangemia. So you need to have a which organism that are common in your hospital. Sensitivity and specificity, very important and crucial. You not want to bring an RDT with a specificity or sensitivity of 60 or 70. You need to have a high sensitive and specificity of these tests. Purchase price. يفرق ولا لا؟ يفرق طبعا. Very important and crucial. You not want to bring a machine that or test that is very expensive, and you will have an issue with a cost effectiveness for these. So cost of fluorescent, if you are using this type of the RDT test supply, اجي اجيب الار دي تي عندي في المستشفى ويقول لي والله السبلاي واقف في الشحن للساعه. طب انا ايش استفدت؟ ف you need to have to make sure that you have a test supply that not cutting. laboratory space، يقول لي الدكتوره مها انا ما عندي سبيس، اسمح لي، ولا مايكروبيولوجي ولا احد، دكتور احمد فقيه يقول لي انا I don't have space please يعني take انا already I have already full of machine in my microbiology, I cannot accommodate this. So you want to make sure that you have also a space in the lab. Complexity of the test. هل هو معقد التست ولا هو test يعني can be done by it needs special training. Shall I need to provide a training for those who provide the test or not? So pre-implementation, as I told you, you need to pull a data for identify the most useful RDT based on يعني ال hospital pathogen you have. For example, number of staph bacteremia you have, number of pseudomonas, number of coagulase negative or number of candida species, and also identify hospital cost. How can I pull the hospital cost? Most of our hospital is as a governmental and difficult to pull the cost, but you can communicate with a warehouse to pull these data, especially for the length of stay, the 30-day readmission for this, and time to the effective therapy. This is you need to pull these data before I'm implementing or choosing any rapid diagnostic test. Let's move on. You implement it. So what you need to do? Because of the time. So we need to have validation of this test. This is the first step. It will be done by the microbiologist to have a validation of these tests. Determine of the test done in the real time. By the way, we have a molecular test in our hospital بس تحدهم الساعة 5. بعد الساعة 5 ما حد فيه. So after 5 p.m. till 8 a.m. I don't have any. If لو كلمني الاي سي يو الساعة 9 في الليل قال لي عندي جرام نيجاتيف في البلد، أنا I don't know what to do. لأنه I don't have like rapid diagnostic test tell me what's organism. So I will start broad till we have the next day المولكيولر team حيجي ويسوي لي rapid diagnostic test. So I need to know if it's available or no. Communication of the RDT result from microbiology to the physician and ASP pharmacist is established, and ASP pharmacist physician educate the medical staff. طيب post implementation what I need to measure. جبت الرابد دياجنوستيك تيست ومبسوط، عندي البايوفاير ولا عندي السفت ولا عندي الماشين هذا الفانسي. what post implementation what I need to measure. ايش رايك دكتوره؟
ايوه how it will affect the cost the antimicrobial the DOT all صحيح.
Time to discontinuation صح؟ I have the rapid diagnostic test. What's the time to discontinuation? I discontinue pharmaco within 48 hours, for example. So time to discontinuation of the or de-escalation, time to ID consult. For example, I want each Klebsiella or each staph bacteremia to be seen or assessed by ID, documented negative blood culture prior to hospital discharge, 30-day readmission. This is all post-implementation and mortality. You want to make sure that mortality, for example, is not effective or not increase or not decrease. Summary, so significant advance with the newer technologies have been made in the microbiology rapid diagnostics for bloodstream infection, for respiratory tract infection, for GI infection, for CNS infection. This allows for sensitive tests for multiple organisms at the same time. And this technology lead to appropriate antimicrobial therapy, improve clinical outcomes when coupled. This is very important. If you have effective rapid diagnostic test, you need to combine it with antimicrobial stewardship program. So conclusion, antimicrobial stewardship, use the right drug at the right time, at the right dose for the right duration. While diagnostic stewardship, obtain the right test in the right patient in order to use the right drug at the right time, at the right dose, for the right patient, for the right duration. يعطيكم العافية جميعا.